Hello, my name is Alina Sunwar Subedi. I'm one of the student nurses at Western Sydney University, Parramatta campus. The main purpose of today's presentation is discussed on the case study 2. So here are the contents of my presentation. In my first slide, I will discuss about the high priority clinical signs and symptoms of the patients to initiate med-call. Then in my next slide, I will discuss about the pathophysiological association with those high priority clinical signs and symptoms of the deteriorating patient. Similarly, I will also discuss the pathophysiology and connection of the symptoms with hypoxemic respiratory failure secondary to asthma exacerbation, followed by the management plan. In the given case study of patient with acute exacerbation of asthma, the clinical manifestation such as tachypnea, severe hypoxemia, and hypercapnia indicates the high priority requirements for med-call. According to NSW Health 2020, it is mandatory to perform A to G assessment of deteriorating patient and interpret the clinical information to record in the patient healthcare record system. During the A to G assessment of patient in the given case study, several clinical signs required the need of escalation to med-call. Firstly, the critical clinical concern for the patient is severe hypoxemia with the oxygen saturation of 77% in room air. Hypoxemia is the result of ventilation-perfusion mismatch in the gas exchange between alveolar and capillary that can potentially lead to respiratory failure. This means, due to thickening of alveolar capillary membrane and imbalance of the equilibrium, the blood oxygenation process becomes limited that may lead to multiple organ failure. Similarly, the patient's signs of breathing difficulties and use of accessory muscles lead to muscle fatigue and high chances of respiratory arrest if not escalated on time. Secondly, PaCO2 of 120 mmHg and PaO2 of 49 mmHg identified as hypercapnic respiratory failure is another important clinical manifestation that needs an urgent escalation. Due to hypercapnia, there is more chances of respiratory acidosis, that means high PaCO2 and alveolar ventilation impairment. In this case scenario, the patient has high PaCO2 and low pH that indicates respiratory acidosis due to CO2 retention and inadequate ventilation that may lead to respiratory arrest. So the worsening of hypercapnia requires urgent intervention of intubation or treatment strategies. So it is crucial to escalate the findings to the medical emergency team in the case study. Thirdly, the patient is tachypneic with respiratory rate of 38 breaths per minute, has dyspnea and tripoding, which indicates escalation to medical emergency team. Tachypnea is a compensatory mechanism for increase in work of breathing as a result of muscle fatigue and tiredness with high chances of respiratory shutdown. Hence, the immediate intervention and escalation to the medical team is needed as the patient has severe hypoxemia resulting from hypoventilation, tachypnea, and hypercapnic respiratory failure with PaO2 less than 60 and PaCO2 greater than 45 mmHg that might lead to respiratory arrest or multiple organ failure in the worst scenario. In the given case study, the patient has clinical signs and symptoms of hypoxemia, tachypnea, hypercapnia, and respiratory distress. These are the clinical manifestations of acute exacerbation of asthma that lead to hypoxemic respiratory failure. So let us discuss about the pathophysiological connection of this clinical manifestation to the underlying condition. Due to bronchospasm, chronic airways inflammation, and mucus hypersecretion, there is airflow limitation in acute exacerbation of asthma. In the case study, the patient experiences shortness of breath, wheezing, and cough with increased sputum production. The air trapping in the lungs due to bronchospasms lead to abnormal expansion of lungs volume, which lead to increased work of breathing for the patient. So this additional effort of respiration results in use of accessory muscles for rapid exhalation and loss of fluids in the form of sweat and breathing. The inability of patient to tolerate oral intake in the case study may cause dehydration and thickening of secretion from persistent cough and wheezing sounds. So these secretions are the indications of obstruction in the airways and bronchospasm, which is due to ventilation-perfusion mismatch. Hypoxemia in the case study is caused by the low ventilation-perfusion mismatch with inadequate alveolar ventilation due to bronchoconstriction. Furthermore, tachypnea is a sensitive indication of severity of acute exacerbation of asthma. Normally, the body is compensating with the increased work of breathing by accessory muscles due to the severe hypoxemia and demands oxygen delivery to the bodily tissues. Similarly, the arterial blood gas report in the case study shows severe hypercapnic respiratory failure with PaCO2 of 120 mmHg, PaO2 of 49 mmHg, and pH of 7.16. This shows the hypercapnic respiratory failure with respiratory acidosis and hypoxia. Hypercapnia is caused by alveolar hypoventilation due to increase in PaCO2 in arterial blood due to enhanced work of breathing or emphysema. So the patient in the case study has hypoxia and decrease in alveolar ventilation that leads to hypoxemic respiratory failure. Thus, the clinical signs such as tachypnea, hypoxemia, and hypercapnia are related to the pathophysiology of acute exacerbation of asthma that progress with inflammation in airways, bronchospasms, mucus production, ventilation-perfusion mismatch leading to impaired gas exchange and respiratory failure. In the case study, the clinical manifestation of the patient is clear while relating with multiple disease condition and pathophysiology of asthma exacerbation. The patient's history of smoking has exacerbated the asthma, which is considered as one of the risk factors associated with the mortality of asthma patients. The characteristics of asthma, such as chronic inflammation of airways and hypersecretion, causes contraction of bronchial smooth muscles, airway edema, and hypersecretion of mucus, which causes acute exacerbation of asthma. So the patient may experience obstruction in airways, impairment in gases exchange, and respiratory arrest as evident by his clinical manifestation of dyspnea, severe hypoxemia, and hypercapnia. Also, the prolonged use of high dose of corticosteroids such as prednisolone and budesonide for the management of symptoms of asthma may have high chances of lower tract respiratory infections such as Pasteurella multocida presented in the sputum culture in the case. In addition, the patient decreased oral intake may exacerbate the likelihood of hypovolemia and eczema, also known as atopic dermatitis, which is closely associated with asthma due to environmental triggers, genetic and weakened immunity system. So all these multiple disease conditions further exacerbate the clinical signs and symptoms of the patient in the case with high risk of respiratory arrest. The nursing management plan for the patient with acute exacerbation of asthma leading to hypoxemic respiratory failure with the symptoms of hypoxemia, tachypnea, and hypercapnia has following immediate interventions: oxygen therapy, use of bronchodilators and corticosteroids, and use of non-invasive ventilation to enhance alveolar ventilation and correct respiratory acidosis. Firstly, The immediate intervention for the patient in the case study is oxygen therapy. It includes oxygen administration to the patient along with the pharmacological therapy to improve the arterial blood gas levels and alveolar ventilation. But the patient with severe hypocapnia is intolerable of high level of oxygen unless the ventilation is well supported by non-invasive positive pressure ventilation. The initial oxygen therapy for the patient with hypercapnia may be via low-flow oxygen nasal cannula and Hodgson masks 15 liters per minute to improve the oxygen saturation. Whereas, if this initial treatment is not effective, intubation or mechanical ventilation is the optimal oxygen therapy for hypercapnic patients. Secondly, bronchodilators and administration of IV corticosteroid are important aspects of management plan for the patient in the case study. According to Peacock 2020, asthma exacerbation causes bronchoconstriction that narrows the airway and tachypnea as a compensatory mechanism. Patients use accessory muscles for breathing. The initial treatment of acute bronchospasms and respiratory distress is use of bronchodilators to relax the smooth muscles of the airways. The bronchodilators increase the diameter of the airways to relieve bronchospasms and facilitate breathing. Short-acting beta agonists are primarily crucial for the management of symptoms of asthma exacerbation. Also, during the acute exacerbation phase of the patient, IV administration of corticosteroid is crucial to reduce the airways inflammation and airways edema. These interventions aim to focus on the pathophysiology of acute exacerbation of asthma to reverse the airways obstructions and correct ventilation perfusion mismatch that results to elevate tachypnea. The continuous monitoring of vitals including tachypnea, lungs auscultation, oxygen saturation, and ABC report is crucial to evaluate immediate response for the deteriorating patient. Lastly, the patient in the case study has hypoxemic respiratory failure, which can be due to various reasons, such as low ventilation perfusion, alveolar hypoventilation, and insufficient oxygen in the alveoli. To address hypoxemia and hypercapnia, the focus is to apply positive pressure to increase FiO2 with the techniques like CPAP or PEEP to eliminate residual gases such as CO2, open narrowed alveoli, and widen the airways. The non-invasive positive pressure ventilation reduces the workload of breathing and prevents further respiratory complications. Having said that, positioning the patient in high fallers is crucial to maximize chest exertions and decrease the use of accessory muscles for breathing. Similarly, it is crucial to monitor patients' reaction to the oxygen therapy, including respiration rate, changes in mental status, and analysis of ABC to ensure the patient reaches therapeutic range of oxygen delivery. Also, hydration is crucial, especially for the patient with the reduced oral intake, to liquidize the mucus secretion and prevent airway obstructions. So it is recommended to commence IV fluid infusion of crystalloid fluid to ensure hydration to the patient. Hence, the management plan involves the appropriate oxygen therapy, administration of bronchodilators and corticosteroid to relieve airway inflammation, and use of non-invasive positive pressure ventilation to improve alveolar ventilation and prevent further complications. If the patient further shows the signs of deterioration, despite the use of supplement oxygen and non-invasive positive ventilation, then mechanical ventilation or intubation is needed. So as a nurse, it is crucial to monitor the signs of deterioration in patient with close monitoring of respiratory rate, oxygen saturation, and ABC report. So this is the end of my presentation. Here are some of the list of references that was used for the research. Thank you so much, and have a great day.